to the Center's Nursing and Health Research bi-monthly webinar. And I'm just so excited today to have our two speakers, Dr. Kelly Lackie and Dr. Stephen Millar. And just before we begin, I'd just like to acknowledge that Dalhousie is in the ancestral and unceded territory of the Mi'kmaq, and we are all treaty people. And I just I think, you know what, for the topic today, maybe Kelly, I'll just let you guys introduce yourselves and the topic, if that's all right, because I don't want to take a lot of time away from you both. So Kelly, I'll let you take it away. Thank you so much.
Thanks, Marcia. Appreciate it. So yeah, folks, I am Kelly Lackie, and I'm assistant professor in the School of Nursing, as well as the associate director of simulation and interprofessional education in the School of Nursing. And I work closely, daily, with my colleague, Dr. Stephen Millar, and I'll hand it over to him to say hi.
Yeah, so very excited to be welcomed here today, and always fun to present with Kelly. So yeah, so I'm Steve Millar. I grew up around here. I am a emergency medicine physician at the QE2 Health Sciences Center. So if there's big bags under my eyes, that's probably why. As anyone knows, what's been going on in the healthcare system. So I'm the Associate Dean for Continuing Professional Development and Medical Education Research at the Faculty of Medicine, and also the Director of Simulation at the Faculty of Medicine. And as Kelly said, Kelly would almost be my favorite nurse ever, but that's actually reserved for my mother.
It has to be your mother, Steve.
Who probably taught me more about interprofessional education with our supper chats around the table growing up than almost anything I've learned since.
Yeah, absolutely. And like, yeah, I'm not joking. We really do meet almost every single day. And so today we're going to present to you a scoping review that we conducted with a team of healthcare providers. And I'm going to share my slides, and then I'm going to hand it over to Stephen. And you let me know when you want me to change slides, Steve, and I will do that, because I probably can't see anybody when my notes come up. So I'll share them now. All righty, here we go. And I'll just move this down here. Okay, and so Stephen and I, with a research team, conducted a, there's Steve in the bottom corner, I'll just leave him there, conducted a scoping review that explored interprofessional collaboration between health professional learners when breaking bad news. And so I'm going to hand it over to Steve and acknowledge our research team.
Yeah, thanks, Kelly. And you know, not only is it fun working with Kelly, and the research we do and the curriculum we develop is fun, but working with this team that you see, you know, I really want to highlight the expertise of the team and the ability of our team to pivot over the last couple of years, because while some on the team are purely in the academic circles, others do clinical work as well as academic work, and for everyone there has been a truckload of change that none of us could ever have predicted when we put in to get this Living Lab grant to do this work. So it's kind of been a labor of love, and you know, we've all learned a lot. And honestly, you know, while I developed a lot of the curriculum related to this, Kelly really is the research engine. She has a much you know, greater depth of knowledge when it comes to research than I do. So I certainly bow to her when it comes to much of this stuff, that's for sure. So we did apply for that, the grant. This is actually, just to highlight it to folks here, annually we have a Living Lab a grant fund through the Faculty of Medicine that's administered through my department, Continuing Professional Development, Medical Education Research. We have about $25,000 available as kind of startup funding for medical education research projects, which can be in any realm, really. And that will be becoming available in January. And I think actually projects that have an interprofessional flair are probably viewed as more what I'm not sure what the word is, more valuable maybe because of it pulling in a team of people that are centered and focused on a particular area of research. So I think they're looked upon very well. So I certainly would encourage other folks here, if you're working in teams of health professionals, to consider that. I'm probably going to talk a little bit more than I usually do, and probably Kelly will too, because usually we're under the gun doing a 10-minute presentation. So it's actually nice to talk about a few things. And I don't know, Kelly, are we going to present and then have questions at the end, or do people want to ask throughout, or how do we want to do that?
Yeah, what I would say probably at the end. So yeah, so John, it'd probably be easier for us to interact online that way at the end. Yeah.
Absolutely.
Okay.
Okay, so sounds good. So let's go to the next slide, please. So just a little bit of background. So before kind of we developed this kind of scholarly work and doing this scoping review, probably about 6 years ago, I'm pretty academically involved in our emergency medicine residency program, as well as with undergraduate medical education. And at that time, I held a portfolio in undergrad at the Faculty of Medicine that included interprofessional education. So our residency program director at the time, Dr. Janet McTar, having done a sort of a new survey of the program, sort of found that there was a huge gap in terms of breaking bad news, which is something I kind of did the math on this. Like if you're working in an acute care environment, whether it be emergency medicine, critical care, or whatever, whether you're a physician or a nurse or, social worker, I forget, like during the course of your career, it's something like 20 or 30,000 times you'd be breaking bad news, in a sort of a 30-year career, right?
Mhm.
So this gap was exposed, and she asked me if I'd put together something for our learners to focus on this. And so, when I thought about it, I thought to myself, when I am really breaking bad news, and it definitely happens frequently in emergency medicine, it's pretty rare that I will go in alone to break the bad news. When someone has died as a result of a motor vehicle collision, a sudden death as a result of a myocardial infarction, whatever it might be. Usually there's quite a team involved with this, and there might be ongoing medical care being delivered. And typically it would be a physician, oftentimes a nurse, as well as a social worker. Or a combination of that kind of team. So that to me seemed like an important thing to do, to include those sort of learners when we were developing the curriculum. So we, and the first thing, I guess, when we thought about this scholarly work was really kind of diving into the literature and figuring out, is this a problem? It was a gap in our program. I think Kelly knew it was a gap in, the nursing program. And sure enough, when you look at the literature, there is a gap in the literature in terms of breaking bad news for health professional learners. And it again, according to the numbers, we know that we must prepare our learners to be able to deliver it skillfully. It does receive little attention in the curricula, and so this was something that drove us to produce a piece of curriculum that was important, viewed as valuable by our learners, valuable by the faculty, to kind of put that together. And what we learned from our review at the time was that, we know, and there's studies out there showing that health professionals do feel inadequately prepared to deliver bad news. And when individuals in healthcare teams or healthcare teams have that discomfort and that not well developed ability to do it well, it leads to compassion fatigue, increased burnout symptoms, moral and emotional distress, all sorts of things that can lead to people leaving professions and or not performing well in the profession they're in. We also know that through study of patients and families who experience this terrible type of news, breaking of bad news, that when it's not done well, that they experience increased distress, impaired long-term adjustment to the new prognosis, whatever that might be, and that it actually can have health effects on the surviving or family members, when it's not done well. So we know that it affects the healthcare professionals. We know that it affects patients and families negative if we don't do it well. So it's really important. This is a skill, and it's often felt to be a soft skill. You know, this is a communication skill. And as everybody knows, when you learn about communication skills when you're a student, you're like, whatever. It's just that's a soft skill. It's not. We want to be have blood and guts, right? When they're young and full of I won't say what we're full of, but anyway.
We'll stick with vim and vigor.
Yeah, vim and vigor, something in vinegar. Yeah. So anyway, that's a little bit of the background. Is there anything you wanted to add, Kelly, to that?
No, I think you covered it very well. Thanks.
And so the next slide. So when we, after we kind of did a couple of runs at the curriculum, developing a workshop initially for emergency medicine residents and nursing students. We did that a couple of times, and then we're kind of like, we think we can do something more with this. The students enjoyed it, we enjoyed it, and they valued it. And because of what we found in the literature, we thought we should take it further and do a scoping review. And so we developed our team, and most of the team that you saw early was the same team that delivered the curriculum. There might have been minus plus a couple of different folks, but this is pretty much the same team by and large that worked on the scoping review. So we wanted to identify and describe the pedagogies that were used to teach interprofessional health learners how to break bad news collaboratively in interprofessional teams. So that was really what we wanted to figure out. And the review question ended up being, what pedagogies are used to teach interprofessional health professional learners how to break bad news collaboratively? There are no wasted or minced words there. We actually spent a lot of time figuring what our review question was going to be. It doesn't seem that complicated, but one of the things when you're doing a scoping review or I guess any type of research is really trying to boil the question down and make it simple, clear, and concise. Because if you don't do that, then you're going to end up going in a whole bunch of directions that you might not have wanted to go. So I think this kind of helped keep us on track. And whenever we lost our focus a little bit, we'd come back to what's our question, what are we trying to do here, and what's the data we want to gather. So next slide, yeah. So when we were figuring out the inclusion criteria for our participants, we looked at undergraduate and or postgraduate learners from 2 or more schools in the health and or social care professions. We were looking at university or college level learners who were working towards a professional health or social care qualification or degree. And we did decide to include, to exclude lay, complementary, alternative, or non-health and social care professions. And I think correct me if I'm wrong, Kelly, but I think a lot of that had to do with regulatory bodies and how we are regulated,
right.
and also thinking about how the natural teams of learners would come together, and we really wanted to stay focused on that kind of thing. Anything else there, Kelly?
No, that's exactly what we were, because we did talk about the fact that there are lay caregivers, there are those in complementary medicine or alternative medicine positions who would help people through the life-altering diagnosis. However, they most likely wouldn't be there when that information was broken. So we absolutely right, Steve. We decided to stick with those regulated health professions that would most likely be around when that's happening. Yeah.
Exactly. And so, again, the inclusion criteria, thinking about the concept, we were looking at studies for studies that explored breaking bad news and tying it explicitly to interprofessional education. And this is where language matters, so you think breaking bad news is a pretty easy to find term. So there's many different terms that describe what breaking bad news might look or sound like. So that was an important thing to figure out what were the terms we needed. So, and we decided on breaking bad news. It was any news that significantly and negatively alters the patient's view of their future. Typically related to dealing with or providing news on a terminal diagnosis, or very unpleasant events. And the other important definition here, and you'll understand as Kelly goes through the results why it's important, interprofessional education. So I just want to kind of underline this, and Kelly will too. We both come from backgrounds where we worked in very broad healthcare teams with many professions working together in the critical care unit and in emergency medicine. You know, it's impossible to work in those areas without team-based work. But I think if you went and asked probably 90% of the people who are working in those situations what interprofessional education means, I think what they'd mostly describe is probably interdisciplinary education, which is more parallel education as opposed to members or students of two or more professions who learn with, from, and about each other. So that's there are multiple interprofessional health competencies in many countries of the world. Canada uses CIHC health competence, interprofessional competencies, and this is the definition of interprofessional education that we adhere to. So learning with, from, and about each other to improve the collaboration and the quality of healthcare services. I guess the thing to highlight is we were looking at this in acute care settings, and we felt the bad news for our definition had to be very bad news, acute bad news, you know, that was being delivered on the spot. So we were dealing with unexpected, unforeseen requirements to break bad news rather than the management of, you know, for example, a disclosed diagnosis, something that might, you know, lung cancer, and maybe the lung cancer's progressed and they're finding that out in emergency department or in some other setting. So that is breaking bad news, but it's a little different when you've already, you know, you've got a potentially terminal or significantly difficult diagnosis. And another area we did not look at was studies that explored medical assistance in dying or palliative palliative care around certain diagnosis. Again, those are all conditions where you've been exposed to the bad news. It's already been broken initially in many of those situations, and it's a little bit of a nuanced setting that we felt didn't quite represent what we were looking for.
Yeah, absolutely.
Yeah. And so our inclusion criteria in terms of the context, again, we were looking at studies that were conducted in academic, educational, or professional practice settings, curriculum-based activities, or continuing education that used interprofessional education as a theory-based pedagogy. We didn't have any restrictions based on geography, location, gender, ethnicity of learners, or other demographic components, although I think we did restrict it to English based language.
Or English translated, or English, because that's our primary language of the team. Yeah,
we're good, but we're not that good.
No, we're not.
The types of the sources were experimental and quasi-experimental, qualitative, and mixed method studies. I don't know that I need to go, you know, we looked at text and opinion papers, conference abstracts, a lot of other things too that we looked at. A lot of those things we ended up excluding from the current study. And while they might, a lot of them didn't have the primary evidence or rigor around the development of the work in those sorts of publications, or and so sometimes they were helpful to inform some of the background work or some of the thinking that we had kind of working through different sections of the paper, but we didn't actually use them as a primary reference source for the paper. Anything else, Kelly, that you wanted to?
Yes, the same with systematic reviews. So we excluded systematic reviews, but we scanned them for any primary research that would have been relevant to this study. So other than that, yeah.
Absolutely. And so the methods that we used, so that we did the JBI kind of 3-step process, and this was definitely a learning curve for me. And I think Kelly, I think you'd done initial training in JBI,
yes.
But I think that this was the first scoping review that we did, and of course there's been more since and more coming. So yeah, the 3-step process to develop the search. And the process includes, number one, the initial keywords being identified. Number two, the analysis of the text words contained in the title and abstract. And three, the analysis of the index terms to describe relevant reviews. Our initial search was conducted February 11th, 2021, which seems like a long time ago, and it was, but the time has flown based on everything that's happened. And we actually did much of the work after that. We updated the search on May 17th. And, everyone knows COVID. We have waves of COVID that people, our heads went under the sand and then they'd pop back up and we'd get back to it. But we finally got there. We looked at Medline, CINAHL, Embase, the Education Resource Center, and social work abstracts databases were all searched. We actually had a librarian with us on our team. And let me tell you, if you want to have there's someone who is worth their weight in gold to help a research team. If you're looking for members that you need on your research team, I would strongly encourage that. We had reference lists of included papers that were screened. Title and abstract screening through to data extraction were completed by 2 independent reviewers, and then any disagreements were resolved through discussion or with a third reviewer. It was a fair bit of work, but it was actually interesting work, and it was relatively enjoyable work, I have to say. I don't. So that takes us up to the results section, and I'm going to turn the mic over to Kelly at this point.
Awesome. Thanks, Steve. Yeah, and I would echo that. It was a lot of work, but when you're passionate about a subject, it's not as bad as you think it will be. And yeah, and the health sciences librarian was a godsend, and you really can't do this kind of work without that person on your team to support you. I don't think, anyway. So what were our results? Well, as you can see here, and I know that it's a busy looking slide, but I will say there were a total of 1,162 papers that we pulled to review. And on top of that, there were studies that were identified by other methods. So from citation searching, from reference list reviews, we did get those papers. Some we couldn't retrieve, some were no longer available. Of course, getting rid of duplicates, and then conference abstracts we didn't include either. So on the right hand of the screen, the sources of evidence that we retrieve from other methods other than database searches, there were 0 included in the review because they didn't meet the criteria that Stephen presented earlier. But when we identified studies from the databases and registers, that's where the totality of the 1,162 papers came from. So before we screened, we removed those duplicates, and then we screened, we title and abstract, we removed about almost 400, 386. We sought those for retrieval. We could get them all. We assessed them for their eligibility against our inclusion criteria. So as you'll recall, that's around participants and concepts and context. In 12 of those 33 papers, breaking bad news wasn't discussed. Not according to our terms of definition of breaking bad news, which is that initial transfer of information that has that life-altering or limiting diagnosis. 9 of them weren't research papers. 8 of them weren't interprofessional education as we define interprofessional education. And our definition, as Stephen mentioned, of interprofessional education is based on the globally accepted definition of interprofessional education. And that those 3 keywords of learning about, from, and with, if that wasn't evident in the papers, then the papers were excluded. 3 papers didn't have student learners, and as you'll recall, our participants were undergraduate and or postgraduate learners. That would include medical residents, for example, in the postgraduate learner base. And then one of the papers was learning about team steps. And for those that aren't familiar with team steps, it originated in the United States. It's a wonderful resource for how to communicate from a team perspective, but it's not necessarily situated always in interprofessional education, and this particular paper was not about breaking bad news. So we included 13 studies in our final review after we went through the title and abstract and full text review. I will note also that calibration exercises were done at each of those 2 stages. So what that means is that we randomly pull papers, a couple of papers, people on the team, reviewers, everybody scores them, and then we come together to talk about how we would have scored them. Would we have excluded them? Why would we have excluded them? We spent a lot of time really hammering out those definitions, even after we spent a lot of time hammering them out before the scoping review started. After that first calibration exercise, it was really valuable because, you know, for someone that's situated in interprofessional education and have been for many, many years, for me, it was very quick to go, yes, no, yes, no, yes, no. For others that are more situated in breaking bad news and not IPE, it wasn't that easy. So it was a really valuable opportunity to hammer out what we really meant and what papers could get in and what couldn't. We also did that again at the data extraction phase. Before we got into data extraction, we again included papers, we extracted data, and we compared those and then resolved any conflicts and once again massaged those definitions a little bit better. So yeah, there was a lot of discussion amongst the team, which I think was very valuable for the process. So what did we find? Well, out of the 13 papers, 8 of them were from the United States, which isn't surprising. Big country, a lot of work being done in the field of breaking bad news and interprofessional education. All but one study that we included used simulation-enhanced IPE as the preferred methodology for teaching an interprofessional mix of healthcare students how to break bad news collaboratively. And so just as a reminder, simulation-enhanced IPE is interprofessional education that uses simulation-based education as the modality in order to teach the curriculum. And Stephen, at the beginning of our presentation, talked about us as a team and most of them on the scoping review team developing curriculum and for breaking bad news collaboratively. And so over the years, since like 2017 or 16 when this started, we use simulation to do that. And first exclusively with medical residents and nursing students, but then we incorporated social work students in the last couple of iterations. And so we were very pleased, I think, to see that the majority of studies that are trying to teach breaking bad news collaboratively are using simulation-enhanced IPE to do so. Most of those sim IPE sessions were face-to-face in the papers that we reviewed. And that is significant for us because, you know, in this era of COVID, at the beginning of COVID, all of our simulation-based learning, including uni-professional and interprofessional, shifted to a virtual platform. And in another study that I conducted, and during that time, we found that students really preferred synchronous online simulations if they couldn't get together face to face. That's always something that we'll keep in mind for the future, because although most of these were face to face, we do know that students do really like synchronous online sims. And our interprofessional simulations this year at Dalhousie will continue virtually. But when we run this Breaking Bad News sim again, you know, we'll have to see what the state of the world is at the time, right? 3 of this 13 studies that were included reported their simulations as high fidelity. So fidelity in simulation really is about how real the simulation would replicate what they'll see in the practice setting. And so when we in the simulation world talk about fidelity, it's high, medium, low. There can be a range as how close they actually get to being representative of real life. So high fidelity sim would replicate actual patient scenarios as much as they can. And considering physical fidelity, environmental, psychological, and any other component that we would consider that we need to have in place to make it real for students to buy in. Low fidelity sim are those things that you try as much as you can to make it real life, but it lacks a lot of those integral components. So an example of that would be like task training to maybe intubate a patient or start an IV, so that they're learning the skill and the task, but it doesn't replicate that physical fidelity of doing that on a real person. So, another example would be sensitive exams. So prostate exams, pap tests. We use actual people, right? What we call standardized or simulated participants, which are the actors that portray patients. So in sim, in those sensitive exams, we use live people so that healthcare learners can learn how to do these skills. And so when these 3 studies reported as high fidelity, what that means is it wouldn't be, for instance, using a paper-based case study to talk about how I would interact with patients to break bad news. It would actually be in a place that we would try to replicate as much as possible what that environment would look like, who would be there, and use simulated participants to do that. 12 out of 13 studies did use simulated participants, and those are the actors, but you can do that in a low fidelity climate as well. The majority of participants in these studies were undergraduate. And interestingly enough, 3 of the studies had a mix of undergraduate and graduate participants, which means that the undergraduate students would actually work with those who currently hold a license. So they may be with audiologists, they may be with nurse practitioners or other physicians and that kind of thing. And that the range of health professions was quite vast for only 13 papers that were included, from A to Z. You know, the people that you would think would be around for breaking bad news, but not surprisingly, medicine and nursing were equally in the majority. And that happens in a lot of the work that we do. They're the largest number of healthcare providers typically.
Can I just add something, Kelly?
Absolutely, yeah.
It just kind of came to mind, you know, when you know, the multiple times we put this workshop on, like for the learners, one of the things we learned over time was the importance of matching the level of learner, because we didn't always do that. Like initially we had emergency medicine residents, which would be postgraduate, you know, that they've completed medical school, and then they're postgraduate year 1 to potentially year 5. So there's quite a bunch there. And we initially used like senior nursing students. We'd had junior or bachelor of social work students involved at one point. And what we ended up finding out was you really need to have learners who are on the same wavelength. Like, you know, emergency medicine residents, nurse practitioners was a group we went to that really have the experience and the ability to kind of relate to these things more, and then master and social work students as well. So when you look at these things and you think about those, you know, the mixed undergrad and graduate, you definitely see power differentials that we probably didn't actually read about in the papers. But when you think about how you would want to develop a research project in a research study, you kind of, as you're going through the papers, you're like, that's not how I do it. That's not how I do it. When you come from a lens of putting on an iterative kind of workshop, and it gives you a very clarity of insight into how you'd want to put something together. You know, it's
Yeah.
interesting.
Absolutely, Stephen, and it brings up. We also conducted another scoping review with a different team on that explored the enablers and barriers to psychological safety in interprofessional simulation. And this, you know, the power differentials are a key factor in whether or not students feel safe enough to speak up in these interprofessional learning environments. Because there is this power dynamic, and what you'll see is students step back and allow those who are most senior within and senior, I mean, if they're graduates or, if they're nurse practitioners as opposed to Bachelor of Science social work students, you'll see the step back and allow those that I think have more power and hierarchy than me take over. And it's not a really good learning environment unless you know how to establish psychological safety, which is another project that Stephen and I are currently conducting, where we're developing an education module on how to establish psychological safety in interprofessional simulation. Because when you do that, then you can mix those learners. So I think it was very important for us, and we learned through our mistakes along the way over the past few years, for sure. What we also found in this scoping review was that breaking bad news was only defined in 5 of the studies. And so in those 5 studies, they talked about the emotion. Breaking bad news was coming upon those emotions and reactions when patients receive distressing, severe, life-altering and/or life-limiting diagnoses, or any information that would adversely, seriously, or negatively alter one's view of their future. The rest of the included studies, so 8 of these studies, did not have any definition of bad news. And when we reflected upon this, we know that certainly in I would say in any field, but certainly from an interprofessional field, it's really, really important that people get the language right so that we know the difference between interprofessional, interdisciplinary, uniprofessional, multidisciplinary, because they all mean different things. The same thing arises in breaking bad news. Like, what did the authors of these studies mean when they were breaking bad news? Was it the initial insult of that news for people, or was it there's a change of diagnosis from a life-limiting diagnosis that you received a while ago? So it makes it hard when you're trying to figure out what's the best way to teach interprofessional learners how to break bad news if we don't know if the study is really talking about bad news as the way we're talking about bad news. Another thing that arose was the Spikes protocol was used as the breaking bad news framework, and that was identified in 5 of the 13 studies. And one other study used the consensus guidelines for breaking bad news, which is great if you know what Spikes is, right? If you know what that protocol is used for. And in one of the studies, the result of one of those studies is that there was a professional group of students that had no clue what Spikes was, and therefore could not engage in the sim as much as they would have wanted to because they didn't know what Spikes was. And so Spikes is heavily used in medicine, and it's a framework to break bad news. And each one of those letters stands for a certain component of how to do that well. So making sure you have the right setting, that we're clear about those perceptions and perspectives that people would have about what's happening currently, that there's an invitation to have that back and forth communication, making sure that people are aware, so that knowledge piece, that there's empathy and emotion, and that the person that is breaking bad news then summarizes what they've just shared and then can conclude that conversation. But if students from other professions aren't attuned to that protocol or aren't introduced to it before they go into the simulation, it has an effect on whether or not they learn how to break bad news collaboratively. And you can put yourself in that situation, right? Like, if I don't know what people are talking about, I'm not going to feel psychologically safe enough to speak up. So I'm just going to shut up and sit back here and nod and smile, right? That also, that concern about using protocols also arose from the interprofessional perspective. So although 85% of the papers identified an interprofessional construct, so for example, communication, Or they talked about specific interprofessional competencies that they might focused on within their simulation. So conflict resolution or interprofessional leadership, that type of thing. 4 papers, only 4, noted that they used an IP competency framework. Not surprisingly, 3 of those papers used the IPEC core competencies because they're US based and the majority of the papers came from the US. So that wasn't surprising to me at all that they used IPEC competencies. There were some studies from Canada, and they did not use the Canadian Interprofessional Health Collaborative competency framework, which was, kind of interesting. Instead, they used the ICAR, the Interprofessional Collaborator Assessment Rubric, which is an offshoot, and I can speak to this because I'm one of the designers and authors of the ICAR, so I was happy to see that they used it, but that was developed almost at the same time that the National IP Competency Framework in Canada was developed. So so I think it's because it was a tool, and the IP Competency Framework in Canada hasn't been put into a tool. And then the other framework that they used was the McMaster Ottawa TOSCI, or the Team Observed Structured Clinical Encounter, which also uses those interprofessional competencies. Anything to add there, Steve?
I think just that we were surprised, like that when you're looking at, interprofessional education, breaking bad news, collaboration between learners, and communication is a huge interprofessional competency that I think we were all kind of shocked that there was so little adherence to any of the interprofessional competencies in the papers. It was surprising.
Yeah, and on reflection and doing a lot of work in IPE, I think because it is seen as an adjunct and not a pedagogy. Like and so a lot of things are called interprofessional that aren't actually interprofessional because people aren't understanding of what that actually means. So of course, we certainly address that in the discussion piece. So our conclusions, certainly from this scoping review, is that SIM-IPE was the preferred pedagogy to teach an interprofessional group of learners how to break bad news collaboratively. There were high levels of satisfaction reported when SIM-IPE was used in BBN because of the realism of the experience, the authenticity of the cases that were developed. And I would say, on a side note to that, if you're going down this road with any SIM-IPE, is to make sure that the people that are designing the scenario are representing the professions that are going to be performing in the simulation scenario. There's nothing that will derail your SIM-IPE quicker than if it is developed from one professional perspective, or it's developed from the perspectives that aren't even going to be in the room. The relevance to practice, that SIM-IPE brings that realism, and therefore students could actually see themselves performing this way in the practice setting. The importance of having interprofessional teaching teams when conducting SIM-IPE to teach students how to break bad news, and that there is a focus on not only how to break bad news, because that can be done uniprofessionally, but how to do that as a team. How do we actually teach students how to perform the interprofessional competencies so that they then can perform breaking bad news collaboratively? Really important. Learners also in these studies identified the value of working together, because they were then able to perform their really distinct uniprofessional and critical competencies to do that, but also were aware then that there was interrelated roles that overlap and that are required. And how do we navigate that and negotiate that with one another? Big learning. And we've seen that in our own SIM-IPEs and Breaking Bad News, that students have reported that. Interprofessional debriefing was also identified as critical. to helping learners attain these skills. And interprofessional debriefing is nuanced and takes training to actually navigate the hierarchy and power differentials that we see in the sim, and then have to debrief that within after the simulation with learners. Learners in those studies also identified that they wanted more varied cases and more breaking bad news tools that are familiar. And I talked about that a little bit about the spikes protocol. So all the students should be familiar with the tools that would be used in a simulation. They also identified that feedback from simulated participants help those learners be able to practice their skills and make mistakes. And it's okay to, like, we want students to make mistakes in sim IPE, and in order to do that, they have to feel safe, and it has to be a risk-free environment. And SPs help learners have that feeling of safety. What we did note, we talked about before, was the inconsistency in language. And so I don't know, but it's one of my, I think, the hills I will die on probably, is I'm really, really a stickler for what do we mean by that, and are we using the correct terminology? I'm very much a stickler for using competency frameworks for both Breaking Bad News and interprofessional education. And then another piece of this is there are healthcare standards, simulation standards of best practice that we should all be adhering to. And many of these studies did not adhere to those standards of best practice. And one of those standards of best practice specifically pertains to simulation enhanced interprofessional education. And so critical, if you're going down this road, is knowing those standards of best practice. And what we've identified as further research that needs to happen is, how are those standards of best practice being implemented in sim IPE? Are they, and what isn't? Do those sim experiences result in enhanced learning about the process of collaboratively breaking bad news? We need to delve deeper into that, and whether or not what they learn is retained over the long term and then incorporated into their practice. And we haven't seen any studies that actually have followed students through that transition. So stay tuned. That will probably be our next foray into this. So our references are pages long, so they're available on request. And that will be it for now. And I'm going to shut this down and stop sharing. And we can actually talk about, let's see, there we go.
Amazing, just amazing work. So interesting, so applicable to what so many of us do. And just going to open the floor up for questions that people might have for you guys.
Great, thank you, Marcia.
While people are thinking, I just want to add to one of Kelly's comments a little earlier about oh gosh, I can't remember exactly how you phrased it, but anyway, it had to do with sort of the development of the curriculum and making it authentic. But one of the things that is really important, and not just having the professions represented, that's what it was. I was like, I'm at a loss for words. I knew if I talked long enough, it would come to me. but it's also having we had like the A team simulated patient educators come in, and the A team also know the A team simulated patients. So when you're developing this kind of a curriculum that really needs to hook people and be realistic, you need the A team simulated patients who can make it, it's like going to a movie. You kind of forget you're participating in it's that suspension of disbelief that they could make you feel it, kind of thing. So I think that was really important too. And we didn't get in some we got a feel for that, but many times we didn't really get a feel for that. And again, it comes with the retrospectoscope when you've done this type of work, and you kind of think of, oh, I know what I do, and if I do one of these again, kind of thing, right?
Yeah, absolutely. Like not using your friends and colleagues to be the patient.
Yeah.
Don't do that.
Yeah. So I'm just looking to see if there's
Oh, Marcia, you froze. Unless I froze.
No, you're
Everybody
good.
else is moving. Oh. We lost your sound, Marcia. Does anybody have any questions for us? Or comments or concerns or
And
yeah,
we're
go
okay
ahead,
if you
Carol.
don't. We're okay if you don't.
We're okay if you don't. Yeah, exactly. Go ahead, Carol.
Okay, thanks. That was great presentation. Really interesting. And I've heard about this IPE sim. I've never been involved in it, but really fascinating to hear about you talk about it and your great work on reviewing it. I really am interested in the idea you talked about it with power dynamics and matching up the appropriate students to work together, because I've seen this a fair bit. Kelly, you were saying when the nursing students step back and you know, especially when we do the trauma IPE in the fall. But you know, a great idea to match people, the NPs, with the any strategies or ideas on how we can approach that as facilitators before the IPE, you know, to try to address that idea of stepping in and not stepping back.
Yeah, absolutely, Carolyn. And I will note that Carol and Kim and Catherine and Noel and Leanne, who is a fabulous SPE. And am I forgetting anyone, Steve? And Steve and I. Who else? Shauna on our team. Anyway, we're developing that site safety module. And so I would say, Carol, that's probably key, that I think there's a lot of prep work that has to happen before they walk into the sim, like the actual sim, right? And I think there is that uni-professional discussion that needs to happen, as well as the interprofessional discussion. Would you not say, Steve? Right?
Yeah, absolutely. This is one of the things that we spent a lot of time on this, actually, like was making sure or trying, and it didn't always work.
No.
Even though we thought like getting the different points of view, you know, from nursing, from social work, from you know, emergency medicine, and even though we thought, you know, and it seemed to be social work that for whatever reason, like a couple of years ago, remember, they thought it was the best thing since sliced bread, and then
Yeah.
the more recent one, they felt they were not included in it. And we had actually gone to great lengths with, you know, Marion Brown and trying to kind of coach it along so that we had prompts and built-in things to really make it work. So I guess it kind of speaks to the fact that you need to work together as a team, but you probably need to pilot some of these things. And it seems you all know when you're developing this work and doing this kind of work that it seems like it's like a train coming down the track at you, right? There's not enough time, and all of a sudden it's time and you have to do it. And you're like, well, yeah, in an ideal world, I wish I could have piloted this, because then you probably would have seen some of these things. And that's probably something I'd underline as being important, having the time built in to pilot it with a couple of learners to just kind of see if it hits the way.
Yeah.
You
And I
want
think having that frank conversation, right, is that I know you're going to be scared. You're probably going to be intimidated. But here's the flash. Everybody's intimidated. Sometimes the people that talk the most are the most intimidated. So help each other out, right? And it's okay to make a mistake. This is where we want you to mess up.
Spending time with the psychological safety of the learners. And you know, we were the people that know this, and we said we could have done a better job, you know, and it's, you know, having appropriate icebreakers and mixers so people kind of feel kind of used to each other, that they kind of know each other a little bit before they get into it, because it's a tough thing when you're bringing learners together from different uni-professional realms that haven't worked together. So I cannot underestimate the importance of developing that safety. Yeah.
Yeah, and that's, you know, Sherry's work focuses on building that sense of belonging, and it's critical. Go ahead, Sherry. You can speak to it better than I can.
Oh, sorry, I didn't mean to cut you off. I got excited when I heard Steve say that. So you guys just really did a master class on scoping reviews too. So great job in walking through the process, because it is really detailed. Yeah, no, I just wanted to say that I have great affection that Steve just mentioned that piece, because I do think that focusing on the similarities, what unites us and brings us together, which is far greater than what is, what it doesn't even divide us, but what distinguishes us from one another is more important. And everything that I've done in terms of longitudinal research and looking at how students relate to one another interprofessionally shows that, and listen, you can't make everybody be friends. We know that. Yeah. But when you do have respect and you can see another person as a person and not a different health professional that you might be jockeying for position when you don't even know what your own position is, if like we need to spend more time there. And I don't know if Noel is on, but I mean, Noel just saw an experience where students who had the time to actually just talk about something else before the sim came into the sim actually sitting in diverse groups. And he said, this is the first time this has ever happened. Usually people come in and all the med students sit together and all the nursing students, but they were already interprofessional. And he said it was, I don't want to take the words out of his mouth or misrepresent, but I think Noah was saying that in all the years of him doing it, he actually saw it. He called me on my cell phone and told me about it right after. So I don't know. I'm really excited about how we can create that, because listen, you go into these situations, you don't need to feel alone, and we're all very scared, and it's really sad to, especially when you think of the topic, which is breaking bad news, and having had bad news broken to me. You really this is something we need to do well. Yeah, I'm gonna stop before I cry. Yeah. Anyway, thanks so much, guys. You did a great job. I have great affection for the both of you. I love you.
Thank you, honey.
Thanks, Sherry.
Thank you. Any other questions? Or are we mosey on?
I just want to thank you so much, Kelly and Stephen. As I said, it's just such relevant, important work. Great review of the methods. I think that was so interesting to people who have perhaps not been involved. Very great learning, and the whole concept itself of breaking bad news and all the elements around the IPE and simulations around that. Just excellent, excellent, really relevant, and keep up the good work.
Thank you. And manuscript will be submitted by Friday, so stay tuned.
Hallelujah.
Hallelujah. That's right, Steve. On to the next one.
So thank you, everyone, for joining. Take care. Everyone.
Thanks for having us. Have a good afternoon.
Thanks. Bye-bye. Thanks, buddy. I'll talk to you soon.
Yeah, bye.